video is about the urinary tract injuries in the laparoscopic gynecological surgery. So this is a very important talk, and very frequently asked questions are taken up from this talk. So you will see that there are many lines in this talk that have been repetitively asked in many of the exams. Okay, so let's start. The article starts with the bladder injury, because this is the most common injury to occur in the laparoscopic gynec surgeries. The rate has been mentioned from around 0.02 to 8.3, and the bladder can get injured during the dissection of the bladder from the cervix, and that is why you can see the injuries mostly in the midline region, in the interureteric bar. Okay, so remember, all the highlights have been questions and they have been asked previously. So remember, the urinary bladder can get damaged because it is near the operating field, and also while the entry process of the laparoscopic trocars, right? The risk factors. So there are few patients who are at risk of having urinary tract injuries, and those patients who have got distorted anatomy have got more risk of having this injuries, because of course the surgeon is not aware about the whereabouts of the ureter and the bladder in such cases. So these are the cases of severe endometriosis, cancer, adhesions like in previous surgery, infections, inflammatory diseases, or a patient who has got radiotherapy, severe genital organ prolapse, obese patients, and patients who are pregnant, right? So the pelvic anatomy is distorted in all of them. Now, how to prevent this injury, the bladder injury? So you have to prevent or avoid making any insertions in the suprapubic region, like for example the Mary's needle. So because the bladder is just below that. Similarly, the insertion of the secondary trocars should be performed under the direct view, because you may just harm the organ which is down there. And remember, the reason why we keep the bladders empty during the surgery is because if it is distended, then of course there is a chance that this bladder may get poked and this injury may happen. So we try and keep the bladder empty during the surgery, so that an empty bladder cannot get penetrated, and it also has got decreased size, so it is easy for us to operate also, right, in that area. Now it is also better to see what are the borders of the bladder, so that can be done by filling the bladder with saline. Also, it can be done by filling it with 200 to 300 ml of dyed rinder lactate, or cytosufflation with carbon dioxide. So all this helps us to delineate the borders of the bladder, and we can avoid going in that area, right? Now there are specific surgeries like LVH, that is laparoscopic assisted vaginal hysterectomies, in which some steps are done laparoscopically and some are done vaginally. So it has been mentioned that in such cases, when you do the laparoscopic assisted vaginal hysterectomies, if you have done maximum of the dissection laparoscopically, then in that cases you are actually pushing the bladder down, right? So when you take the closure, or the vaginal is closed from vaginal end, in such cases, then when you have already pushed the bladder down, you are actually causing the bladder to come at risk of getting injured when you are suturing the vagina vaginally. So try and suture the vagina laparoscopically. If the dissection is done laparoscopically more, try and do the vaginal closure vaginally if the dissection is done vaginally more. So when you are doing the vaginal dissection more, you are pushing the bladder up, so then you can do the vaginal closure from down, right? Now there are four main reasons why the electrosurgical injuries they occur, and remember, most common are inadvertent tissue contact, insulation failure, direct coupling, capacitive coupling. We have seen all of this in the previous video, right? Now, what are the safety measures to take? This is a very important point, and we have seen this in the previous video too. So it is about inspecting that the insulation is working before using an instrument. Then, using the lowest possible power setting, use new response generators, use the bipolars only when required. There should be intermittent activation, use low waveforms of monopolar diathermy because it requires a very high frequency to cut. So use the lowest voltage and do not use it in close proximity with another instrument because it will cause direct coupling. And remember, try to keep the whole of the forceps from heel to tip in front of your eyes whenever you're activating it so that you don't touch any important organ. Now, another important point from the point of view of litigation is recognizing the injury. So when you are recognizing, you can actually repair it there and there itself and also take care of the patient post-op, right? So whenever you have, it has been seen that the bladder injuries are not recognized around half of the times. That means only 50% of the bladder injuries are recognized, and this is a very commonly asked question. Okay, so how will you recognize a bladder injury? The patient will have hematuria in the catheter. There will be the urine bag will be distended because the gas will be leaked out through the bladder. It will come to the urine bag. So keep on seeing the urine and the urine bag before closure of your laparoscopy. You can also do intraoperative cystoscopy or installation of 200 to 300 ml of colored saline into the bladder. This will identify the site and the extent of the injury. So remember, wherever it has been suggested that or it has been suspected that the bladder injury has occurred, do an intraoperative cystoscopy. It has been seen because in some cases where the injury opens into the space of Retzius or retropubic space, then even when you're pushing the dye, even then you won't be able to see the dye coming out. So in those cases, you may be under the false impression that there is no injury, whereas the injury is actually there and opening into the retropubic space. So that is why it has been suggested that whenever you suspect a bladder injury, go for intraoperative cystoscopy. Okay. Now, coming to the injury which is involving the trigon. So wherever there is a trigon injury or injury near the area of trigon, ureteric injury is a very high possibility because the ureters open into that area, right? So you may either do the cystoscopy to find out if the trigon area is affected or to assess the bladder mucosa, or you may do a laparoscopy, and if the injury is not large enough, then you may just put a 5 mm laparoscope with a 30-degree angled lens to see the trigon area and the ureteral orifices. Okay. Now, how to recognize this post-operatively? Post-operatively, of course, the recovery of the patient won't be that good. The patient will have suprapubic pain, hematuria, leakage of urine per vagina, and oliguria. Because the urine is sterile, it will cause the symptoms of chemical peritonitis, but they'll be subtle, and it won't be very severe like that of the bowel content or the infected urine, right? So these patients will have abdominal pain, distension, and ileus, but will not have tenderness. Okay, remember this. Understand that all these complications will occur within 48 hours of the post-operative period, but if there has been a thermal injury, it will take time and it'll appear around 10 to 14 days after the operation, right? Also, the serum creatinine levels will be raised because of the absorption of the creatinine by the peritoneal membrane. Now, how to go about it? So you do a CT scan and find out if there is a uroperitoneum or there is any direct evidence of injury. Then go for a retrograde cystography to confirm your diagnosis, and then do a cystoscopy, assess the injury, and see whether it requires repair. Sometimes it may require repair, sometimes it may just require the conservative management. Okay, whenever you find that the patient is having symptoms of a fistula, then go for the methylene blue dye. So fill in the bladder, retrograde filling of the bladder by methylene blue dye, and then put the swabs in the vagina, that is a triple swab, and then see which one of them gets dyed to find out where the fistula is. Also, MRIs act as a better source for also, and they have a very good tissue contrast and can be diagnostic for vesicovaginal fistulas, right? Going to the management of urinary bladder. So remember, uh, a gynecologist or urologist, both of them can go for the repair. They should have advanced laparoscopic skills. But conversion of it into a laparotomy, it all depends on the surgeon's experience, right? And also on the type of injury that has occurred. The bladder injuries can be sutured in 1 or 2 layers by 2030 observable sutures, that is polyglacting. A running non-locked repair with the sutures are placed 0.5 to 1 centimeters apart, 0.5 to 1 centimeters lateral to the cystotomy angles. Otherwise, you may also use extracorporeal knotting or interrupted sutures can be used 0.5 centimeters at 0.5 centimeters interval. A figure of 8 may be enough to close a small defect. So all these are the methods of suturing the bladder, but the suturing should be watertight and it should not escape any of the urine out, right? So wherever the ureters or the trigon region is injured, you have to involve the urologist, and it should be done. The repair should be done by the urologist. Put in the ureteral stents because we need to know that the urethra and the ureters are patent after the repair, and we don't want them to be obstructed. Okay. Whenever the thermal injury has occurred, you will have to go for the debridement uh, first before the repair. So first do the debridement and then do the repair in cases of thermal injuries. Okay. And also remember, whenever the injury is opening into the space of radius, you may do just catheterization for 2 weeks and manage conservatively if it is a very small injury. Okay, guys. Now, again, remember, when you have placed in the bladder catheter and you are managing the repair, place it for around 2 weeks. Now, before removing the catheter, you just cannot remove it. So you have to do a retrograde cystography, find out whether the dye is leaking. Okay, so put in a dye, see whether if it is leaking, or if you can see the contrast that is escaping, then keep the catheter for another 1 week. So first 2 weeks and then 1 week. Okay, so despite of all this, you may still see fistulas in around 5% of the cases. Okay. Of course, you have to give antibiotics to these patients for 5 to 7 days and keep the indwelling catheter for 2 weeks. Okay, so this was about the bladder injury. Now coming to the ureteric injury, there are different types of ureteric injuries, and they are seen in around less than 1% to 2%. Remember, there has been a question asked on deep infiltrating endometriosis associated with hydronephrosis, the risk of ureteric injuries in these patients. So the risk has already been written, say it is 21%. So it can be really very high in patients who have got severe endometriosis, right? The regions where the ureter can get damaged is at the level of the pelvic brim and also at the level of cervix, because at the pelvic brim it is in close proximity to the infundibulopelvic ligament, and near the cervix it is when we are coagulating the uterine artery, we come very close to the ureter. Remember, around in 25% of the cases, it is the electrocautery that causes damage to the ureters. Okay. Ureters passes lateral to the cervix with an average distance of 2.3 plus minus 0.8, and in cases where patients have got high BMI, it is very, very near to the cervix, right? How to prevent the ureteric injury? So do an MRI in cases with where you find that the complex procedure is going to happen or the patient is high risk, like in cases of endometriosis. Do MRI with or without IVU. Okay, see the pathway of the ureter in such cases beforehand. You may also check the ureter intraoperative by peristalsis. So that is the best way to diagnose which one is the ureter, right? So that helps to identify the ureter. Also, wherever you find that there is too much of adhesions or it is high risk, you may just do ureterolysis. That means dissecting the ureter. You may dissect and mobilize the ureter around 15 centimeter because it has got its own blood supply in the adventitia layer, and that is why it remains viable. Okay, so mobilization is from medial to lateral. I'll repeat again, mobilization is from medial to lateral. Okay, remember the ureteric stenting. It is required only in severe cases where the ureter cannot be identified by any other method and where the pelvic anatomy is severely distorted. Okay. Also remember that in cases of severe endometriosis, the ureteric obstruction and hydronephrosis may be associated, and this in such cases where there is ureteric obstruction and hydronephrosis along with severe endometriosis, preoperative stenting is mandatory. Okay, guys. Again, there is a way of identifying the ureter. It is by illuminating by uteroscope. So what you have to do is the surgeon has to keep the laparoscope still in position close to where the ureter is, and then the laparoscopic lighting is turned down and the ureteroscope is advanced inside the ureteric lumen, and then you can illuminate and see where the ureter is, right? Also, the best way is to reflect the bladder adequately. This will also cause the ureters to fall away from our operation site. So all these are the preventive methods of ureteric injury. Now there are different types of injuries that can occur, and the transection is the most common one of them. Transection, okay? 1/3, that means 33% are recognized. That means 66% of the ureteric injuries go unrecognized. So what are the different types of ureteric injuries? There are 7 types: angulation, crush, ligation, thermal, laceration, resection, and transection. That is the most common of them. Okay. See the picture which is showing the pathway of the ureter here. Okay. So going ahead with the cystoscopy, it allows the visualization of the ureteric orifices. It also shows the urine jets, but it cannot exclude the other types of injuries. So how you can do that? You have to put in IV indigo carmine, and this will turn the color of the urine blue within 5 to 10 minutes. And then laparoscopically, you can just see. So whoever is there at the laparoscopy end, so that person can see the area of injury. Also, it will help in assisting the cystoscopic assessment of the injury also, right? There are other methods like ureteroscopy, retrograde, antegrade, and intravenous uretropylography. All these can confirm and refute the diagnosis and determine the location of injury. Now, how to recognize postoperatively? Postoperatively, these patients will have flank pain, flank tenderness, hematuria, oliguria. It will be seen within 48 hours. Uroperitoneum will show the same way like that was in the bladder injury. There can be sometimes extensive cellulitis. There can be a urinoma, which may develop as a result of retroperitoneal leakage of urine. And this will cause a reactive fibrous tissue to form a cyst with urine inside, which may convert into an abscess and cause sepsis and electrolyte imbalance later on. Okay. So remember, whenever there is a thermal injury, again, it takes 10 to 14 days. And here also you can do CT scans to find out if there is urinoma, hydronephrosis, abscess. But a CT IVU, a CT intravenous urogram, will locate the injury. Okay. So CT scans will find out whether it is there or not, and CT IVU will locate the injury. Now remember, there are many times when the ureter, when it goes unrecognized, the injury goes unrecognized, it may affect the kidney and may result in nephrectomy of the kidney. And it has been seen that unrecognized ureteral injuries can cause eventual loss of the ipsilateral kidney in around 25% of the cases. Okay, now how to manage the ureteric injury? So the minor crush injuries, needle injuries can be kept like that, but you have to see whether the ureter's integrity and viability has not been compromised. Many a times obstruction is managed by just by stenting. Okay. Going ahead, if there is a deep thermal injury, then excision of that affected part and ureteral reanastomosis and reimplantation is required. Whereas if the ureteric injuries like transection, resection have occurred, then if it has occurred at the upper end, at the upper one third, then you may just close the ends together and do reanastomosis, that is end-to-end reanastomosis or ureterostomy. When it happens in the middle, you may go for ureterostomy or go for end to side ureterostomy. That means contralateral, you may just attach this ureter to the contralateral healthy ureter. So that is called as transureterostomy. Okay. When it is down in the lower one third, you may go for ureteroneostomy. That means you have to put the ureter into the bladder. Sometimes it cannot be happen tension free. So in those cases, you have to reduce the gap, and that can be done by psoas hitch or the Bowery flap. Psoas hitch, you have to attach the bladder to the iliopsoas muscle tendon, and Bowery flap, just remove the flap of the dome of the bladder and attach it to the ureter and reduce the gap. So only the methods to repair. Remember, the urinomas can be managed by involving the radiologist, the specialist radiologist. Go for percutaneous drainage of the urinoma, then percutaneous nephrostomy, ureteral stents, and bladder drainage. All this, if you go together or do it combined, then it will avoid reoperation. But if a patient has come in septic state, then of course you have to go for conservative management first, give antibiotics, aggressive antibiotics, and then go for a retrograde urogram or IV retrograde IV urogram before you say that the patient has healed. Okay. So whenever the patient is in septic state, go for the stabilization of the patient first, and then do the treatment, the repair required. And whenever you feel that the patient has healed, go for the IV or the retrograde urogram to confirm that the ureter is patent now and it has regained its integrity. So the first one is psoas hitch. It is attached to the psoas iliopsoas muscle, their muscle tendon, and here Bowery flap, they have just removed the dome of the bladder and attached to the ureter. Okay, all these measures should be done by the urologist, of course. So this is what is important in this talk, and this talk is really very important. Do not forget to revise it before going to your exam. Okay, I hope this must have helped you. Thank you very much, guys.